Linda, you're just on mute.
Can we start, Caroline?
You can. I will just check where our first speaker is. He should be with us shortly.
All right. Good morning, everyone, and thank you for joining us this morning. I'm Linda Lombard, the chairperson of SAMET Market Access Standing Committee. We would like to welcome everyone to the Market Access Forum, which we will take a look at the COVID-19's impact on the market access, as well as how to navigate BHF tariff codes. Just a few admin points before we start. This is a Teams meeting, and as such, we ask that your video is turned off unless you are speaking to assist with the bandwidth, and that you keep yourself on mute. If you want to ask a question, please use the chat facilities or raise your hand, and I will call on you to speak. We will monitor those who actually needs the question to ask at the end of each presentation. So first up, we have Discovery Health Chief Commercial Officer, Dr. Ronald Whelan. Dr. Whelan will give us an overview of Discovery's health perspective on the impact of the pandemic on people's long-term health, chronic conditions, and care. Additionally, he will present on beneficiary spend and on elective surgery, routine medical tests, and associated medical technologies. Ronald Whelan is a medical doctor by training with an MBA. He was an associate partner at McKinsey from 2006 to 2013, during which time he has co-led McKinsey healthcare practices across sub-Saharan Africa. From 2013 to 2019, he was a partner and head of healthcare investments at Spinnaker Growth Partners, where he led investments and business developments across a range of healthcare ventures, and he was a founder of Health Force, a leading telemedicine player in South Africa. Dr. Whelan has extensive experience in clinical and corporate healthcare, spanning more than 20 years and in 25 countries globally. So over to you, Dr. Whelan. Welcome to our forum. You are more than welcome to share your presentation with us.
Many thanks for the introduction, Linda, and great to be with you all this morning. Delighted to be participating in this session. I hope it's going to be valuable for all of you. And I think what I'll aim to do is do a quick whirlwind tour through the world of COVID from a Discovery Health perspective, and then leave enough time at the end for some Q&A. Okay. Let me just lump up my slides.
We have them. Thank you, Doctor.
Okay, so just a quick check, and you can hear me clearly. You can see the slides clearly. Yes, all right, let's jump in. So as Linda mentions, I'm Chief Commercial Officer at Discovery Health. That's sort of my day job. My job though over the last year or so at Discovery has been leading Discovery's COVID response both internally and externally, which has included involvement in the BEEF and BUSA structure. So I sit on the steering committee for BUSA, both around COVID as well as around B4SA vaccine program. And as part of that program, we're working closely with the National Department of Health as well as with the National Treasury around the national rollout of your vaccine. So that's a little bit of my background. For today's discussion, we'll focus on some of the Discovery Health insights. Linda and team asked us to give you some reflections on how Discovery Health has experienced COVID and the impact it's had on the health system as well as on our members. We'll cover sort of three main sections: a view on infections and the trajectory around infections, a view on morbidity, a view on mortality, and then some of the implication on our membership base as well as on your health system utilization. I know you're particularly interested around your health system utilization trends. To start out, just to give you a sense on Discovery's COVID experience to date, as you'll notice from this slide, so we've had just short of 200,000 Discovery Health members with confirmed COVID infections. As you see, the bulk of those infections have happened around Gauteng. That's where the bulk of the Discovery base sits. Also been a significant number of infections in Cape Town, partly driven by the base in Cape Town, but also driven by high prevalence of infections in Cape Town, and then a number of infections in KZN as well. Conducted just short of 1.2 million tests to date. This has been a significant cost driver for the scheme. As you know, tests come in at 850 rand a test, so over R1 billion spent on COVID testing during the last year or so. Just to help you calibrate on that, we typically spend in the order of 3 billion rand on testing. So R1 billion rand on COVID testing is about 33% of the annual pathology spend. We've had 36,000 members admitted to hospital, but 42,000 actual hospital admissions. So 36,000 has been the total number of members admitted. Sometimes your members have been readmitted. So we have had a small readmission rate on hospital admissions, and then very unfortunately, over 5,000 members have died as a result of COVID during the last year. I think what's been interesting to watch is the difference between wave 1 and wave 2. So when you look at some of the differences, I think the first thing you'll notice is that wave 2 was significantly more infections than wave 1. We saw this both in the national data as well as in the discovery data. So about 1.5 times as many infections in wave 2 in comparison with wave 1. Also had a significant...
I know.
Hi, there's someone who's perhaps not on mute. So 1.5 times as many infections in wave 2 versus wave 1. Some interesting stats on the right-hand side of the page. So what you see is we had higher socioeconomic classes were hit harder in wave 2 versus wave 1. That's data that comes out of both Discovery Life as well as Discovery Health. What we also had was significantly higher life insurance business exposure. So almost twice as many, more than twice as many Discovery Life claims paid out in wave 2 versus wave 1. Saw higher admission rates in wave 2 versus wave 1. That was predominantly driven by higher infection rates. But interestingly enough, we saw fewer out-of-hospital claims. So what we found was that the acuity in wave 2 went down in comparison with wave 1, and then the shorter average length of stay. And I think this points to the fact that during the course of COVID, clinicians and the industry more broadly has become more accustomed to treating COVID. Treatments have become more sophisticated. The protocols have become tighter and clearer, and that really has manifested in both hospital claims as well as length of stays. Very interesting to watch is some of the reasons we saw a spike in apologies.
Member choice risks around with all potential. So most all the members are in profile balanced, and the fund at the end of.
Thank you.
Quite a lot of feedback, Linda. I'm not sure.
I will just have a look and see who's not on mute. Sorry about that. Apologize.
No problem. Apologies, the slide's gone a little bit out of sync down the right-hand side of the slide. I'm not sure why it's not displaying correctly. So essentially, there are three main drivers for a second wave outbreak. The first main driver is, as you look on the left-hand side of the page, is Google mobility trends. So what we saw is that increasing mobility through the various stages of reductions in lockdown, culminating in mobility levels roughly back to normal levels in early December last year, and then actually spiking above normal levels in the early parts of December. So that was the first trend. I think related to these mobility trends, what we're seeing in the vitality data is we saw increased nighttime driving, particularly towards the end of November, beginning of December. And nighttime driving is a strong indicator of your social mobility. In addition to mobility, what we saw was some super spreader events, particularly related to the post-matric festivals at the end of November 2020. And what you notice here is this dark blue line is 16 to 20-year-old infection positive test rates. So you see a big spike in 16 to 20-year-old infections towards the end of November last year. That's largely related to those post-matric events. The knock-on this was really impactful, and you can see that those infections then spread into other parts of the discovery base as these post-matric students then went back to families and went on vacations across different parts of the country. Perhaps the most interesting data though on that is when we look at flight data, and we tie Discovery Health data to Vitality flight data. What we found was there's a 16 times higher risk of infection on a flight during this period in early December. And I think that speaks to a lot of your asymptomatic carriers of COVID at the time, with the knock-on impact of your increased risk of infection on flights. So very, very interesting stat there. And then the right-hand side of the page, and apologies, this has come a little bit out of sync, is it was obviously the new variant that came into play. So the green, turquoise, blue, and your orange parts of the slide are the different variants that have manifested in South Africa. You'll see we started off with the 20D variant and the 20B variant. This 20B variant was the main variant during wave 1. And then in wave 2, in fact, this chart overlays almost entirely perfectly. The N501Y-V2 variant was then the predominant variant in the wave 2 infections, and that started to manifest towards the end of October last year, and then it really ramped up during the course of wave 2. So that's really what caused our wave 2 outbreak. One of the things we're really concerned about is reinfection levels, particularly in the context of these new variants. And what we've been able to do from a discovery perspective is look at potential reinfection levels between the different waves. This is a very, very interesting analysis. Just focus on the right-hand side of the page. What we've done is we've analyzed over 90,000 members who had more than 90 days between wave 1 infection and then a subsequent test in wave 2. So we were able to take out a sample of about 90,000 members. Out of those 90,000 members who had tests in wave 1 and tests in wave 2, what we found was that there were 674 that tested positive. So 674 out of the 89,000 members who had tests in wave 1 and wave 2 with an interval of 90 days in between, then retested positive. So that's under about 2% reinfection rates. In fact, a little bit lower than that. What we've also found out of that is that there is a certain percentage of that population that is vulnerable to reinfection. So reinfection rates look like they're low, but there is a significant portion of the population that would be vulnerable to reinfection. I think that is validated by some of the reports in both global and local circles. Reinfection obviously is a result of declining antibody levels over time. It's still not clear around how long antibodies will last, and then obviously is impacted by the new variants. Some interesting stats around our utilization trends, just to give you a sense on hospital admissions for COVID on a daily basis. So you'll see in wave 1, Discovery Health peaked at 300 new hospital admissions for COVID on a daily basis. The system did come under pressure at this point here, but I think we were rescued in that the outbreak was spread over multiple weeks. So it started down in the Western Cape, then gradually spread up into the Eastern Cape and then other parts of the country. The system came under much more pressure in wave 2. So you'll notice here that we peaked at just over 500 new hospital admissions a day for COVID. I can tell you from personal experience, this was a very, very trying time. The end of the last week in December, first week in January, our hospital system was completely overwhelmed. We were flying people out of your hotspot districts to free up your ICU bed capacity, free up your ventilator capacity. We were scrambling for beds even across your Gauteng, and there was a stage in at the peak of wave 2 where hospitals had to revert to ventilating people on your Boyle's machines. So this really, I think, illustrated that's about the peak of what our private healthcare system can manage. Fortunately, as far as we know, not a single Discovery Health member went without a hospital bed, went without a ventilator. So despite coming very close at this threshold, we were able to make sure that everyone got hospital beds. And credit to our hospital partners who we worked with very closely around this period. Fortunately, we've come way back down, so we're under 100 new hospital admissions a day. In fact, it's dropped to about 70 this week. The system is now getting back to normal again, and I think we'd all agree that this is a massive relief. What we've obviously got to be cautious of is a potential third wave. From a sort of a morbidity perspective, what we saw on the morbidity ratios, as you see from this slide here, is we saw slightly more severe infections in people over the age of 50 to 79 during wave 2 versus wave 1. So the dark grey blocks is wave 1 and the green block is wave 2. You see slightly higher COVID-related infections in the elderly populations in wave 2 versus wave 1. From a chronicity perspective, we saw roughly the same picture. So wave 2, wave 1 was roughly the same on a chronic distribution perspective. The place we did see some differential around chronic propensity for disease was in the Eastern Cape. So in wave 2, we saw slightly higher chronic populations affected with COVID, but it's not statistically significant on the national basis. Moving on to some of the cost implications in relation to COVID, I think this is a really interesting slide. So once again, wave 1 versus wave 2. Wave 1, the grey blocks. Wave 2, the sort of blue and green blocks. What you'll notice is that general ward costs on a cost per event basis stayed roughly the same between wave 1 and wave 2. High care costs stayed roughly the same between wave 1 and wave 2. What we did see was lower ICU costs, and that's predominantly driven by lower lengths of stays in your ICU between wave 1 and wave 2, and I think is also due to advances in treatment and clinical protocols. So this is quite a powerful metric around saying we did actually improve your treatment modalities. And then I think we saw some of the metrics around your ventilators. So 420,000 Rand your cost per event in wave 1 versus 357,000 Rand your cost per event in wave 2. From a hospital admissions perspective, I think you'll see more sort of general ward admissions as a proportion in wave 1 versus wave 2. Roughly the same, your high care admissions, and then your slightly higher ICU admissions, predominantly driven by their infection rates. Okay. What also manifested between wave 1 and wave 2, and I think this is really interesting. So I mentioned earlier on that we saw lower acute medicine utilization between wave 1 and wave 2. These are people who weren't admitted to hospital, and I think just the population gradually became more accustomed to COVID, less anxious around COVID, and I think that's driven a lot of that pattern there. What we did also see was then lower likelihood of your oxygen authorization request on your discharge patients. So what you see here is once again here's pre-wave 1, there's wave 1, pre-wave 2, and wave 2. Your ICU admissions here we saw reasonably high oxygen requests post-discharge. But on all admissions, reasonably low your oxygen requests on discharge, and those patterns didn't really change too much across the phases. What is interesting is a higher proportion of patients who were initiated on out-of-hospital cortisone. So we saw increased use of corticosteroids, and I think people became accustomed to deploying dexamethasone in out-of-hospital settings. So instead of getting dexamethasone in hospital, we saw more out of hospital dexamethasone treatments. A big drive, not only by the funders, but also by a number of the providers around home-based care. So what we found in wave 2 was that an increasing number of providers were looking to rather manage people at home. We saw the Donald Gordon hospital in particular driving for more sort of your home-based care, and many other practices across your Gauteng aiming for home-based care. We also, from a discovery perspective, then put an initiative in place where we enabled virtual home consults, particularly for our chronic care population. Given there was a reduction in health-seeking behavior around chronics, we enabled over 7,600 virtual house calls. We had 224 GPs participating in that program and spent over close to 3 million Rand as part of that initiative. What we also put in place was an episode fee for GPs. So instead of admitting your members to hospital. We put a fully bundled episode fee in place where GPs could manage your patients end to end for a COVID event. We had over 1,000 of those events. We spent over 2 million rand on those events. And I think this was both great for members as well as great for GPs, enabled your home-based care. We got exactly the same outcomes. In fact, in many circumstances, we got better outcomes, because what we've seen between the different phases, we've seen lower hospital-acquired infections. So I think we're quite excited about cost per events for broader than COVID, potentially pneumonia and other conditions that can be treated at home. And then we did something similar in the specialist camp as well. We also aim for episode fees in relation to COVID, and I think it points to the future around using home-based care and episode-based fees to enable lower acuity care at home. From a fatality perspective, an important chart just to give you a sense on the mortality rates you've seen through the different phases. As you'll notice from the slide, the Discovery Health case fatality rates. A case fatality rate is deaths divided by positive or confirmed positive infections. You see the case fatality rate has remained roughly static throughout, so somewhere between 2 and 2.5%. It's important to note that your case fatality rate is often overestimates the overall infection fatality rate, and the reason for that is that many infections are asymptomatic or mildly symptomatic, and you don't end up with a positive test. So often we underestimate the extent of the population infected. But I think we were delighted to see that our case fatality rate did remain static. Would like to have seen it come down somewhat, but there was some impact of the new variant in wave 2. This case fatality rate, when you correlate it to the national case fatality rate, is closer to 3.5%. I think it indicates some of the differential between the private sector and the public sector in terms of effective management of COVID. One of the hot statistics in the Discovery ecosystem at the moment, you might have seen this in the press recently, is our actuaries have done a calculation that suggests over 50% of South Africa's population has been infected with COVID. Just wanted to give you some sense on how we do that calculation. It's quite an important calculation. So the calculation is underpinned by 2 solid variables. So when you're doing these calculations, you look for the most accurate variables. And the most accurate variables in the landscape at the moment is, one is excess deaths. On the left-hand side here, you'll see excess deaths for South Africa. This comes directly out of the death register in South Africa, comes out of the MRC. As of last week, South Africa had 146,000 excess deaths. And that excess death would be excess deaths there in wave 1. And then there's the differential on excess deaths in wave 2. When you add up those numbers, you get to 146,000 excess deaths. The second statistic that is very reliable globally is the infection fatality rate. So the infection fatality rate is measured globally by leading scientists globally, most notably the Imperial College in London. Our scientists have done work around infection fatality rate. And what we're seeing out of the literature is the COVID-19 infection fatality rate for South Africa is somewhere between 0.28% and 0.39%. And to help you do this calculation, I'm going to try and simplify it for you so that you can just understand the logic. If the infection fatality rate, for instance, was 1%, and you had 146,000 deaths, 146,000 divided by 1% gives you 14 million. So if your infection fatality rate was 1%, you would have ended up with your 14 million actual infections. If your infection fatality rate therefore is 0.5%, you then end up with close on 28 million infections. And if your infection fatality rate is 0.39%, we've got anywhere between 51 and 57% of South Africa's population infected. So that's how the actuaries do this calculation for us, and we're very confident that these numbers are reliable and accurate. We've then triangulated those numbers with some of the studies out of the South African National Blood Services. A recent study there came out with antibodies found in 52% of your South African National Blood Service samples. And you triangulate that with some of the work that's been done across hospitals and maternity rooms and so on and so forth, that indicates that anywhere between 40% and 50% of the population has antibodies to COVID. So that's a little bit of background around that 50% number, and I think this is reasonably reliable. The issue here is that we're not entirely sure what portion of the population is affected by the new variant versus the prevailing variant, and that obviously has implications on herd immunity and longevity of immunity. Moving ahead to wave 3 projections. So this is obviously the big question in South Africa at the moment. IQVIA have done 3 scenarios on wave 3 projections. So if you look at the left-hand side of the page, here's wave 1, there's wave 2. We're playing 3 scenarios forward. The first scenario is what we call a second wave runoff. This implies that we've got decent herd immunity on the back of a big chunk of the population already being infected, and we would have a gradual runoff on infections. That's scenario 1. If that scenario plays out, we would have then an additional 16,000 deaths across South Africa. The second scenario we played out is this green scenario. This is a scenario where we have super spreader events at Easter with your reinfection on the back of those super spreader events. This is the scenario, obviously, none of us here want to go down, but would result in an additional 90,000 deaths. And then we played out a third scenario where we have super spreader events with reinfections, but with an accelerated vaccine rollout. And you can see the differential between super spreader events and reinfection and the vaccine rollout. So the vaccine rollout could potentially save South Africa 50,000 lives if we accelerate the rollout. Hence all of the impetus around accelerating South Africa's vaccine rollout. I think your core message around this page is that there's real risk around Easter, particularly around your church and social gatherings. We saw what happened in December, and we need to be cautious around the Easter period, both individually, collectively, as well as from a business and societal perspective. And then I think secondly, it's critical for us to get the vaccination program underway, and we've got to be all hands on deck around getting vaccine into the country as quickly as possible. Moving on to some of the health system implications, and I know you're going to be very interested in these pages. Focus on the bottom part of this page. I call this chart our iceberg chart. We've been watching this chart since March last year. What it illustrates is pre-auth admission rates. Pre-auth admission rates to hospital is our best indicator of hospital admissions during the period. And as you'll notice here that during the the level 5 lockdown in March and April last year, hospital admissions on a year-on-year basis dropped by 60%. So a very, very deep iceberg all the way from March right through to May last year. Started to see some recovery in hospital admissions through level 3 at about 40% off year-on-year baselines, then a further recovery to about 20% on baseline from August to December last year. And you can see it by the time it hit the early parts of December 2020. We got back to regular utilization on hospital admissions. So it got back to sort of a year-on-year net 0% effect, and then it started to increases. Utilization started to pick up gradually, but then it's dropped off again. So on the back of wave 2, we've seen a decline in your hospital admissions again on a year-on-year basis, about 40% down. What this has resulted in is an aggregate of 7 billion rand in scheme savings for the year. So the scheme is sitting with a surplus for 2020 as a result of reduced expenditure on your hospital admissions. The big question though we're asking at the moment is how does this utilization then come back? People have obviously, as you see on the right-hand side of the page, we've seen a reduction in surgical admissions, which means that people have delayed treatments, joint replacements, hip replacements, all sorts of surgeries. What was interesting though is we also saw some reduction in medical admissions, and this has potentially resulted in some ongoing complexity in managing chronic diseases. But a very interesting page. So quite a big surplus for the scheme. Big question mark on how utilization now comes back during the course of 2021, 2022, 2023. The COVID pandemic has a different effect on different practitioners across the system. I'll start out on the bottom of the page. If you just look at general practitioners, on an aggregate basis, general practitioners are 22% down on per life per month during the course of COVID. They dropped down by 46% in earnings dropped 46% in the hard lockdown sort of April-May periods. We're now back down to sort of 22s and 26%. That's a significant slump in GP earnings as people avoided going to general practitioners. We saw similar slumps in pediatric visits, which was interesting to watch. Pediatric visits was driven by two things in our view. The first one was reduced health-seeking behavior by patients for pediatricians. And then the second thing that was really interesting is that we saw virtually no respiratory syncytial virus infections during the course of the last year or so. So RSV has, to a greater or lesser degree, disappeared from the landscape. And this is presumably because kids have been out of school and there's been less social engagement on kids. We've seen similar patterns, by the way, on flu. Hardly had a flu season last year, so tiny number of flu infections. That didn't happen only in South Africa, but also happened globally. Orthopedic surgeon visits down because people have delayed elective procedures. And then I think quite worrying, we're sitting with a mental health pandemic. So we've seen a psychologist utilization up, and then pathology utilization is up basically mainly on the back of COVID testing. In addition to all of that, I think very, very concerning for us, we've seen reduced screening and registration for chronic diseases, for oncology screening, so breast cancer screening down by 27%, 23% reduction in the number of breast cancer diagnoses during the period. Diabetes, we've seen 74% fewer wellness tests. We've seen 10% fewer diabetes registrations, 61% reduction in HbA1c tests. And then you've seen 29% reduction in chronic GP consults. So this is of real concern for us. It means that there are undiagnosed breast cancers across the Discovery Health base and across the nationally as well. So very, very concerned about this. And I think suggests that we are going to have more severe morbidity and potentially mortality going forward. I think there's also going to be a significant catch up in utilization. So quite a worrying picture for us, and certainly significant work happening on the actuarial front to make sure that we're pricing utilization and increased morbidity into scheme premiums going forward. And then finally, just to wrap it up, just to give you a sense on the health of the scheme. So this is Discovery Health medical scheme data. As you'll see from this, the scheme is largely flat over the last few years or so. That being said, the whole industry is flat, so medical scheme membership across South Africa has actually declined. Discovery Health medical scheme, though, has gained market share in the last year or so. And we're seeing some quite interesting patterns emerge around the resilience of the Discovery business. If you have a look at your new lives 2020 compared to 2021, you'll see that Discovery Health medical scheme signed up just short of 22,000 less new lives. At the same time, Discovery Health medical scheme had much fewer withdrawals between 2020 and 2021. So in 2020, the same time, we had 64,000 withdrawals. Last year, we only had 58,000 withdrawals. So the differential in withdrawals is declined. I think this indicates the stickiness of health insurance in the context of the pandemic. The reduction in new lives is predominantly driven by retrenchments and the broader economic impact of the pandemic. Plan movements have been very static, so there's been 96% of the base hasn't moved plans, only 1.6% of the base is downgraded, and 2.2% of the base is upgraded. So this is very stable. And I think really interesting to watch is we actually saw our debit order rejection rates sit around about the same level. So people are prioritizing their medical scheme contributions. We did see a bit of a blip in the early stages of the pandemic. We were very worried around this period around lapses, but that has subsequently come back to normal levels. And that's it. A little bit of a whirlwind tour. I'm sure it felt a little bit like drinking from a fire hose, but yeah, happy to take some questions if helpful.
Thank you, Dr. Nguyen. I think this was quite insightful. I don't know if there's any questions from anybody. Please raise your hand.
I think we got a question from, is that Tanya?
Yes.
Go for it, Tanya.
Not so much a question, but just to say thank you so much, and also very, very appreciative of all the hard work that Discovery has done in terms of dealing with the pandemic, and your role at B4SA in terms of the vaccination rollout. We really appreciate you coming and sharing these insights. I found the presentation to be extremely interesting and insightful. And I love the way you've been able to make the links between life insurance and vitality and flights and etc. I think it just shows that probably, you know, all of that and expanding all of that has had wonderful results for Discovery, and how you can use that data to influence and make positive changes. Maybe I do have one question. From a medtech perspective, I saw in one of the slides that in the second wave there was reduced length of time in ICU, and also I think reduction in use of ventilation. Did that have anything to do with maybe any innovative medtech products that came into the market, or different use of those products?
Oh, yeah, well, firstly, thank you for your comments around the collaboration. I must say this has been a wonderful period insofar as your collaboration, and we certainly appreciate the partnership from our pharmaceutical and med device your partners, our hospital your partners. So thank you for your contribution during the period, and we thoroughly enjoyed working with our various partners during this pandemic, and hopefully it bodes similarly for the future. Yeah, I mean, it's interesting. I think we're still trying to discern exactly what the differential was in the length of stays between wave 1 and wave 2 from an ICU perspective. I think what we are seeing conclusively on the data is that dexamethasone became much more mainstream in wave 2, and the timing of the initiation of dexamethasone became much clearer. And it was often tied to clear pathology indicators around, I think it's COP-IL-6. In addition to that, I think we did see increased use of some of the innovator products during wave 2, and I think that would have had some impact on that length of stay. And I think more broadly, there's just increasing your confidence across the market more broadly on managing COVID. And sort of more confidence in being able to discharge folks into general ward beds, and then from general ward beds into home environments. So it's hard to sort of pinpoint exactly what the lever was. I think it was a constellation of factors. Home-based oxygen, I mean, I think it was certainly important, and we drove quite a big home-based oxygen program. So we've got a dedicated team that both provides your pulse oximeters to high-risk population, as well as your home-based oxygen to higher risk populations, and that potentially aided in some of the reduction in admissions and reduction in length of stays as well. Apologies if I get your first names wrong. Is it Donata?
Donata, you can speak.
Hi, thanks for the opportunity. I just want to find a sophisticated way of data analytics, and obviously the effect of COVID in the private sector would be similar to the public sector. Is there a way where you are having some private-public partnerships in assisting the public sector in analyzing the situation on that area, and looking at the impact in terms of drop in cases overall, whether it's elective or or diagnostic cases, will you be able to assist the public sector in a form of a private partnership in terms of handling the backlog, let's say when all the waves have come and gone? Thanks.
Yeah, what a great question. Thank you for that. I must say that has been one of the things perhaps you've been most proud of in South Africa's COVID response is the extent of the public-private collaboration. Not only on PPE and vaccines, but just generally on clinical protocols. Two specific examples there, Donata, that are worth considering. I think the first one is that the public sector helped the private sector enormously. So way back, and people forget this quite easily, Prof. Guy Richards, together with his team across the WITS internal medicine circuit, it's one of the first medical teams globally to use dexamethasone effectively. They were using it for 3 or 4 weeks before the studies even came out. And we have a close collaboration with Guy Richards. We're able to take that information, we're able to disseminate that across the discovery base. And credit to Prof. Richards on making that information available, participating in webinars. Give you another cool example on that. I actually did Prof. Richards in collaboration with Discovery did webinars across Northwest Province, Western Cape Province. We did stuff around in Mpumalanga. I mean, those things were just so valuable in saving lives. So private sector learned a lot from the public sector. At the same time, and not well publicized, there was an initiative at the peak of wave 1 and wave 2 where private sector hospitals had hospital beds capacity made available to state sector patients. And we actually ran, as Discovery, together with some of our other administrative colleagues, ran the administration and reimbursement for those admissions of state patients into private hospitals. So we're able to use that initiative to alleviate some of the burden on public hospitals at the peak of both wave 1 and wave 2. So lots of good collaboration, and right now we're working hand in hand with the National Department of Health and National Treasury around the vaccine program, and been quite exciting to work in real public-private partnership.
Thank you, Caroline. Do you have a question?
Yes, I do, Prof. Doctor, it's Caroline here. I just wanted to check with you. What is Discovery's view on point of care serological tests and the funding thereof?
It's a very, you're speaking to the right guy on that. I'm a big advocate for point of care testing. I think there's real benefit, and I think the evidence is conclusive globally around the accuracy of point of care testing, particularly the antigen testing. So we've have a benefit available for COVID-19 antigen testing, for GPs to use, pharmacies to use, pathology groups to use. I think we see this as an important public health intervention. Must be driven at scale, helps us keep abreast of population infection trends. Important though that data does get stored centrally, so there is a legal obligation to report those test results into the NICD. And certainly, as you've seen from the Discovery data, we use that data to inform a lot of our decision making. So a requirement as part of that benefit that the results are reported into a central system so that we're able to adjust and mold our response. I hope that sort of answers your question. So I think very supportive of certainly your COVID-19 rapid antigen testing. The test kits are good and reliable, and I think most importantly, the clinical data on those test kits is that they pick up infections in the most infectious periods. So certainly supportive there.
Thank you. Is there any more questions, guys? All right, let's continue. Caroline, did Al not join us yet? I can't see her on yet. Yes, she did.
Yes. Thank you, Dr. Whelan.
Thank you for hosting me again, and thank you to all of you on the call for your collaboration, partnership here during the last year or so. Still got a way to go, but I'm sure we're going to get through this year soon enough.
Thank you, Doctor. All right, guys, as we know, 2021 is set to be a year of both challenges and opportunities. Elna Stein, a senior consultant at IQVIA, is going to share 2021 market trends, which have been accelerated by the pandemic, and events and trends unaffected by COVID-19, which will come to fruition in 2021. As mentioned, Elna Stein is a senior consultant at IQVIA South Africa, leading the real-world analytical consulting offering in South Africa, supporting local and international clients in the life science industry. Elna is a pharmacist and has more than 15 years of experience in the pharmaceutical industry and has been with IQVIA for more than several years. Welcome, Elna. Can you maybe share your presentation with us?
Yes, I can. Thank you so much, Linda, for the kind introduction. I'm sharing my screen. Please, if you can shout, if you can see that. Is that visible?
Not yet.
Not yet, Elna.
Okay, let's go out and delete all of that. I'll just close this. I'm sharing my main screen there. And how about now?
Yes,
Perfect.
we can actually just put it
Awesome. Thank you so much. Thank you so much. Thank you for the kind introduction. That introduction always makes me feel so old. But thank you so much, everyone. Thank you for your valuable time. But most of all, thank you for inviting IQVIA to present to you today. We've put together, as our global thought leadership, 9 key trends that we think will be important for 2021 and beyond. Obviously, the pharmaceutical industry as a whole has been through quite a rough ride in the past year, and we find ourselves on the doorstep of a new era, and we are quite keen to see how we could help our partners such as yourself through this period. But first, let's start with some good news. Vaccine development over the past year has been swift, and the rollout has already started, with more than 300 million doses of COVID vaccines having been administered worldwide. And you can see here how for emerging markets, of which South Africa is part of, is leading the pack, of course, due to the large size of these markets. Vulnerable populations are being prioritized, but vaccines will take time, and different countries move at different rates. There's already supply chain challenges with the vaccine delivery, and it's evident that we will not move as fast, specifically in South Africa, as we anticipated. And you can see sort of how low we are compared to the rest of the world. And I think that is to be expected, right? We all thought at the start of the pandemic that it is likely to go slower in South Africa than other parts of the world. But vaccines will only address the infection crisis that we've been faced with. The initial infection crisis put healthcare systems in a state of shock. But now, as the infection crisis recedes, we are faced with 2 new crises. One, of a healthcare system capacity and non-COVID patient backlog. And secondly, an economic crisis, which will constrain healthcare spend in 2021 and beyond. And I think certainly we've all been part of this crisis, these 2 crises that is sort of happening simultaneously, and it will be interesting to see how it plays out. We know for a fact that South Africa has been hit quite hard with the economic crisis. We were in a recession already at the start of the pandemic, and it's just plunged us further in recession with large unemployment numbers at the moment, and that has had a direct impact on our healthcare system and our care delivery as well. The 9 trends that we will discuss here today must be viewed in their context, and the impact will be slightly different in different countries and in different sectors, such as yourself. The opportunity and positive change for the healthcare sector, however, is a common theme that we want to take from this today. Start by just talking briefly about the vaccine rollout and the vaccine positiveness that's been happening around the world. Although the healthcare sector ended 2020 in a very different place to where it started the year, for example, face-to-face visits, as we all knew, declined significantly for both patients as well as industry representatives. Similarly, newly diagnosed and treatment initiation for patients declined substantially throughout the course of the year, as patients were scared to engage with the healthcare sector, and also the capacity for the healthcare sector to engage with patients wasn't always there. This has built a backlog of non-COVID patients in the system. And while the vaccine certainly plays a role and herd immunity is the ultimate goal, these challenges will reduce only slowly and will likely not reverse completely in the coming years. We will still be wearing masks for a long time to come. Social distancing will remain in place and hygiene protocols will continue to be required. Test and trace, and as we've just heard from Discovery, is something that will continue to happen as we also prepare for future third and fourth waves of the pandemic and changes in the current vaccine, in the current vector. May I just ask Linda, I think you're navigating this. I can't see these questions or comments as I'm sharing my screen. Will you interrupt me if there's any questions? I'm happy to take them as I sort of go along.
Yes, I will do that. Thanks, Elna.
Thank you so much. Of course, the pandemic has impacted stakeholders in different regions. We've asked some local industry experts how they thought the pandemic affected patients, physicians, payers, and hospitals. But across the world, we can see that with the lockdown, of course, as we know, there were cancellations of elective surgeries, replacements of face-to-face visits, as we've already spoken about, reduced consultations, reduced impact time, and patients were switching away from complex medical delivery systems that required in-hospital admissions to more oral or self-administered medication options. For the rest of 2020 and into 2021, IQVIA expects that there will be a tough payer environment as budgets are reallocated away from what used to be key drivers of payment and budgets and away from hospitals as they try to make the best of the money that is available in the system to be able to prioritize some of this backlog that we've already been talking about. We think that real-world evidence, specifically in all sectors of the industry, will start being more pertinent as payers are looking for actual evidence that the new and novel therapies are working and are bringing the savings that the healthcare providers are talking about. The digital impact, we think will be seen for a long time to come. We're already seeing patients using online channels to communicate with their physicians, their insurers, their pharmacists. Virtual consultations through various platforms are already taking place in South Africa, with key players such as Discovery driving a lot of this innovation in this space. Payers, as I've already mentioned, like Discovery and many others, are promoting virtual consultations, but they also face a shrinking patient base due to affordability and unemployment. Hospitals are faced with having to relook patient volumes and the backlog and are using advanced analytics to identify patients, improve their scheduling and inform treatment sequencing to make sure that the higher risk patients are advanced through the system earlier. Throughout 2020, IQVIA's data, secondary and primary research pointed to often substantial share of non-COVID patients receiving no or suboptimal treatment. Addressing the patient backlog and the consequences thereof will be a prominent topic in 2021 and beyond. Pharma and medtech both must play its role in supporting the post-pandemic healthcare system and recovery. Some of these initiatives can include supporting telehealth journeys with technology, such as linking devices and wearables to diagnostics and digital companion and apps. To ensure sufficient stock and the reinforcement of the supply chain, we've already seen significant out of stocks and initially early on as a result of the significant uptake of things like PPE. The need for self-administration devices and less options that are less reliant on hospital admissions is necessary to help the healthcare system cope with what's going on. And we need to grow and improve the quality of remote and digital engagements throughout the system, and everyone, including us at IQVIA, play a role in this area. And then there's, of course, Caroline asked a question just now about developing rapid COVID testings and vaccines will become key to allow future resumption of normal healthcare and sort of a return to what we like to call the new normal. We know that there's been a backlog. These are some small examples of where the backlog is most acute, but we've all felt it, we know about it, but how do we work together to move this forward is key going into the new year. The COVID pandemic poses launch challenges specifically. We've, unfortunately, because of our lack of data in the medtech industry, we've used a former example here. But global data for 2021 suggests that there's only been a few successful launches in the global market as of date. It's a challenging environment, and only, as you can see, 3 launches have been classified as being excellent in the last year, and that's mostly as a result of the US sales, which have exceeded $100 million in the period year to date, August 2020. Innovative launches are difficult when it is not easy to see your key role players, when patients aren't able to get to their physicians to be switched from one treatment option to another treatment option. And then, of course, the whole dynamic market that includes switching and starting new treatment is really difficult to navigate in this new environment. It is likely to not change in the coming year significantly, although we do expect to see more face-to-face interaction. It will likely not go back to what it was pre-pandemic. So we need to find, as an industry, a way to launch successfully in this changing and new environment. The other side of this really difficult launch area is the fact that there's price pressure in the system that is going to put lots of pressure on everyone to make sure that we provide cost-effective care, because we are expecting reimbursement challenges going forward. As you can see there, and as we well know, countries' GDPs fell on an unprecedented amount in 2020. And whilst we are expecting a bounce back in 2021, as lockdowns start to ease and economies are being reshaped with a sharp increase in unemployment. So it is likely to not go back to what it was pre-pandemically. While healthcare sectors generally weather the economic storms well, there are a few challenges this time around. Firstly, the strain on the healthcare system with already stretched resources. And then secondly, the reduced ability to realize savings from existing products that are going off patent. The example on the bottom left-hand corner is from global sales, and you can see in 2029, $183 billion were about to go off patent. That amounted to about 30% of the 2009 sales. This year, or in 2019, that same value of products that are about to go off patent is about 200 billion. Although almost similar in value, the difference there is in small molecules, which is easy to be switched to a generic versus biologicals. Almost 44% of the drugs that are going off patent in the next 5 years are biologicals, which requires, specifically in South Africa, a new prescription from your prescribing GP or HCP, as you're not allowed to just switch to a new biologic. You have to have a new prescription. And in there lies some of the challenges that we are about to face. And even though this example is around loss of exclusivity in the pharma sector, there's likely to also be quite a significant price pressure on the medtech industry as savings are being looked for elsewhere because of this sort of increase in biologics and biosimilars that are about to hit the market. And we know the price of these things, and payers and funders alike will start to look at alternatives to be able to make savings in other areas of their business. As interactive time with GPs is likely to remain scarce, companies need to be even more ruthless in prioritizing the content and value adds that they bring to HCPs and make sure that they remain relevant. We've not, unfortunately, have this type of data available in South Africa. We don't track these, but you can see how detailed contact time has fallen in some of the European states, or and even in China, where they were sort of one of the first ones, and you remember some of our previous engagements where we've showed you more detailed data. So even though total contact time have reduced significantly in Europe and in China, face-to-face contact time was significantly less. We've also asked doctors around the world, South Africa was included, but it's not separate in the stats that we see, that there's a lot of frustration currently with content delivery, and not everyone is very satisfied with what they're finding through their content. There is definitely a preference globally towards more digital, and it's driven specifically by some of the younger physicians. And on-demand information is preferred because it allows HCPs to interact when they have time and not necessarily when someone is waiting for them to see them in their rooms. But we know, and I think we've seen it in South Africa, that it's not yet perfect. There's so many different ways to interact online and remotely with HCPs and your staff members alike. But there's room for improvement, and it's the overall satisfaction is just over 5.6 out of 10. While the technologies and logic for home healthcare delivery and greater digital engagement existed prior to the pandemic, adoption has been accelerated greatly as a result thereof. We know that telemedicine is key to remote healthcare and has grown due to COVID. Discovery Health reported late last year that they've seen a 30-fold increase in virtual GP consultations from 2019, where it was almost non-existent, to 2020. The regulatory enablement obviously had a huge role to play to ensure that you can have a remote engagement with your healthcare professional, but it remains only permissible where there's an established patient-practice relationship. Digital technologies that enable home healthcare, such as UCB's MediSafe epilepsy portfolio, will support patient engagement ongoingly. And then also recently, the FDA has approved a platform using biosensor wearables and AI analytics, which has been rolled out in the US to facilitate acute hospital care at home programs, which has greatly helped patients be more interactive with their healthcare providers from their houses. And then we also think that self-administration, as we've already mentioned, and novel dosing regimes will help free up patients from clinic visits. A good example of this is not yet available in South Africa, but MSD's gained approval from the regulatory authority to reduce Keytruda's treatment regime by half, thereby ensuring that you only have to go to your HCP half the time compared to previously. The benefits to stakeholders are clear. Patients are empowered. It's also more convenient. It increases their adherence, but it also helps overcome mobility issues, specifically in countries like South Africa, where patients often stay very far from their closest clinic or healthcare facility and has to take time off work and travel extensive distances to be able to get healthcare. Healthcare systems obviously save time and capacity, and they are able to handle the COVID backlog, as well as the pressure that's being put on them to ensure everyone's vaccinated better, because they have fewer patients walking through their door. And then, of course, the payers, they have the cost saving on their side. Shorter interactions means lower costs. We also know that the telehealth option was initially offered at a reduced cost, but it also helps them maintain contact between the patient and the healthcare provider to prevent these patients that are not receiving treatment to at least have a regular contact with their healthcare professional. Then I think this is not a new trend. It's something that we've seen for quite some time, but it has been accelerated quite significantly by the pandemic. Is the influence of the Chinese pharma industry and their appetite for innovation. And interesting enough, they've not been hit by a second wave as most of the other countries in the world. And they've had a great appetite for launch and innovative launches in recent years, as you can see there on the left-hand side. We also know that this is impacting us locally in South Africa, and I think quite significantly in the medtech industry, where South Africa's procurement policies have long favoured imports over local manufactured products, and there's been little financial support to local manufacturers for basic medical devices such as masks and gowns and gloves and surgical items that could quite easily, that is considered low tech, and it could quite easily be manufactured locally. But we've seen sort of government looking elsewhere to larger countries like China and India to have these. And the Chinese rise to being a former global powerhouse has just continued over the years, and they've not had the dip that we've seen in some of the other large economies. And then another area which is also not new, but it has been highlighted quite significantly by the pandemic, is the CNS renaissance of sorts. The 2020s were the decade of oncology, and while it is still likely to dominate the 2010s were the decade of oncology, and while it's still likely to dominate the 2020s, the growth is likely to slow down. But CNS has re-emerged with a large prevalence and a large unmet need. Technologies will certainly have an impact and will be an important differentiator in the CNS area. We can see there's some of the suggestions that we've had and that we've researched through digital biomarkers and enabling technologies such as apps and devices that helps patients to track and be better compliant to their treatment and make sure that they remain into the system and connected to healthcare professionals all around. Then another area which is of lesser importance to this audience, but it is something that we are keeping an eye on, is biosimilars. I've already spoken a little bit about it and sort of the impact of the biosimilars in some of the major economies. In South Africa, it's something that is still fairly in its infancy. We've only really seen a couple of biosimilars enter the market, and also as things progress at SAHPRA, we are likely to see more of those. It is a cost-saving initiative that will be pounced upon by the system as a whole, but as I've mentioned, it is likely to not be very pertinent to this audience. And then just lastly, if 2020 was a crisis year, 2021 will be the year of transformation. We've seen major healthcare shifts. We must all adapt to what is called this new normal. But specifically in a launch environment where we have to find new and differentiated ways to launch products into an area where we don't have the regular face-to-face meetings that we used to have, or the large meetings launch arenas that we were all privy to in the past. There's this non-COVID patient backlog that must be addressed. And that is made worse and more difficult by the fact that now healthcare providers are providing vaccinations and getting vaccinations, and that is creating another backlog at healthcare facilities. Of course, in terms of market trends, prices will be scrutinized. There will be an increased pressure to demonstrate value. The disruption in terms of HCP engagement continues, and we expect that will be a lasting change. We don't think in South Africa that we will go to a full digital interaction with HCPs. We do expect that there will be a combination of face-to-face and digital going forward. But there's an increasing digital and self-administered awareness amongst healthcare professionals and patients alike. We've mentioned CNS as an area of relevance. The crisis has resulted in quite a significant upsurgence in patients with CNS abilities, but we do believe that there's solutions in digital and tech that we should be looking at. We've spoken about China's rise in the pharma market and their keen interest in not just being a generics player, but also being an innovative player, and in the biosimilars that will grow into more maturity in other markets, but will certainly come into its own in the South African market. And then, of course, there's the vaccines, which is pertinent to all of us. But even successful vaccinations will not result in a business as usual. It is likely to take quite a long time, and the backlog that we've been talking about still exists. There's also likely to be more waves and more variants to the strain that the current vaccinations might not be able to tackle, and that we will only know as this disease develops and we see more evidence of that. That was, in short, my story. I'm happy to take some questions or comments if anyone's got something, and I'm happy to also share this presentation after this.
Guys, do we have any questions for Alma? So Alma, maybe just a comment from my side. I think I've really enjoyed the last slide, and I think 2021 is definitely the year that we can expect a lot of new changes. And as you mentioned, a way of that the funders and hospital groups are going to look for efficiencies. So I think that's something that we need to focus on.
Awesome. Thank you so much, Linda. Thank you, everyone. Thank you for your time. I'll be sending this presentation through to Caroline, and I'm sure she'll distribute it internally. Thank you for your time, and have a good rest of your meeting.
Thank you, Elna.
Thank you. Bye-bye.
Bye.
Okay, guys, so next up is battling to get a BH tariff code for your new equipment for use in hospital and learn how. So I would like to share my presentation with you. If you guys can just give me a sec to get this up and running. Just let me know once it's visible to you. Can you see my presentation?
Yes, Linda. Thank you.
Thank you. So I was thinking of, let's start at the beginning of what is a tariff code. So a medical aid tariff code are used by all medical aids and schemes to indicate the type of treatment or service provider and then the associated costs. Each of these codes have a specific amount attached to it, which actually determines the rate at which any medical service provider will be paid. The pricing for each code is determined by the Department of Health and certain industry players and published in the annual National Health Reference Price List, or the NHRPL. Next slide. Just trying to get to the next one. So what is the meaning? So codes are very specific for each healthcare profession, meaning that the GPs or the general practitioners would have a different set of unique codes, and so does physiotherapists or dentists or gynaecists. So each code has a specific rand amount attached to it, indicating the price which should be paid for a specific service or procedure. The medical aid tariffs are revised annually based on hospital negotiations. It is then published as the National Health Reference Price List, or in short, the NHRPL, for that specific year. Medical aids may use these guidelines to determine the amount paid for each tariff code, and most medical aids will pay according to that NHRPL rate. So what will happen if, let's say, for example, they will only pay 100%? So if we're moving on to the next slide, what if amount is higher than the recommended tariff amount? So as you know, some medical professionals and healthcare providers charge above the tariff stipulated in the National Health Reference Price List. Although individual practitioners are entitled to do so, this does not mean that the medical aid has to pay the amount above and beyond the NHRPL tariff. Any difference has to be settled directly with the healthcare provider by the medical aid or by the patient, coming from your own pocket or from your MSI. Some medical aids have now opted for higher rates with certain medical professions, particularly specialists, and usually only within the hospitals. And we can also see in most of the biggest funders that they negotiated certain networks with certain doctors, where they will put a doctor into a category A, B, or C, where they will recommend that they will pay, if the doctor belongs to a category, 150% or 300% of the NHRPL rate. So I think, guys, what you would like to see is actually to understand the process of how to obtain the in-hospital equipment tariff. So we're going to look at two processes. The first one is the in-hospital equipment tariff. So first of all, there's a need or a desire from the supplier. So the funding or the demand for a new or existing tariff code for equipment. So it could be something new or it's already in the country, but you would like that tariff amount to be increased. So what you should do is each and every hospital have a hospital technical management division. So you will address that with the technical manager to review the technology. And it will be based on the current technology available. And then superiority have to be proven. So for example, if there's already a capital equipment placed in that specific hospital group, it's up to you as the supplier to prove your superiority, not for yourself or for the ease of the surgeon, but for the patient or for the funder or for the hospital. What will happen then is that the technical manager will then approach the funder, motivation will send to the funder to review or create a new tariff code. The funder then will go back to the supplier and at that specific point can ask or request an HTI or a health technology assessment from the supplier to review this technology. Only once approved, the funder will create the tariff code, but the tariff code will be with the hospital based on the annual price negotiation. So let's say, for example, it could be Discovery or it could be MedScheme. Those specific funder will go back to the hospital, and between them, they will agree on the new tariff code and they will agree on the price if you can prove superiority. So the decision or the outcome will be based, like I explained, on superiority or on cost saving or cost offset analysis. So if we talk about cost offset analysis, if your new capex or your new capital equipment, let's say there's maybe a price difference from the old technology versus the new technology, it's up to you as the supplier to prove to them that initially it will cost you higher, but within the next year, there could be a saving in your readmission rate. It could be a safety advantage the new technology have, or it could even help with readmissions into the hospital. So I don't know if there's any questions at this specific stage before we move on to the surgeon tariff code request.
I don't see any questions at this time, Linda.
All right, then I will move on to the next slide. Oh, sorry. The next process is, and I think this is where the need is, the doctor-specific equipment or tariff. So how can a supplier assist the doctor to get a new equipment tariff, or if you feel that the existing tariff code is not in line with the pricing for that specific CapEx? So again, here the need will arise from the surgeon. So it could be a normal equipment tariff demand for new equipment or to obtain a higher tariff request. Here, it's up to the surgeon to approach SAMA, your South African Medical Association. Again, the surgeon have to prove superiority of this new technology. SAMA will then send a recommendation through to the funders. The funders' clinical team will then review the recommendation, and then again with SAMA's and their recommendation, they can go back and at this specific point again, request for a health technology assessment from the supplier. Once approved and based on SAMA's recommendation on tariff and on rand value, it will get approved. But again, guys, here it's up to normally, let me give you a specific example. We're all familiar with normal lithotripsy. There was a company that brought in now cardiac lithotripsy. There was a tariff code for urinary lithotripsy, and the technology was demonstrated to the surgeons. Some of the surgeons was actually using it in a few cases, and they were really keen to use it in cardiolithotripsy. So what happened is they actually went, a panel of the doctors went to see SAMA. They put their review together and also the outcomes of that specific cases, and then based on that, the funder then granted a new code for cardiac lithotripsy. Guys, is there any questions regarding how to obtain or how to increase new tariff codes, whether it's in hospital or out of hospital, or whether it's from the doctor's point of view? I can't see any specific questions.
Linda, I see there's a hand from Tim Andrews.
Hi, Tim, please.
Good day, Linda. Thank you very much for allowing me to ask a question. With regards to these processes, are we actually educating the likes of the hospitals and informing them about the protocols? Because we tend to get mixed correspondence from the different groups. So what is protocols that is been followed to educate the hospitals with regards to the protocol, with regards to the registration and getting the tariff codes in place, etc.?
Thanks, Tim, for the question. I was in consultation with the major 3 hospital groups and with about 5 of the funders before this presentation to understand what is the requirements. And I can tell you that from the major 3 hospital groups, they are all in agreement that this should be the process. So the request should come from the technical department. So you need, as a supplier, need to create the demand at the technical department for your equipment there.
No, perfect. Thank you very much. I think we'll utilize information shared from this meeting and just take it up with the groups, because similar situations we've come in and we may come right at 2 of the groups, and then one of them would come back and tell us that we need to follow up with the likes of Discovery, or we need to do that. And when we approach, and then we get the similar feedback as in, no, the hospital needs to. But then another question in relation to that, is it confirmed that tariff codes only applied for once a year or twice a year and cannot be done on a regular basis?
Yes, it's actually, all right, as you know, the funders years start from the 1st of January till the end of December. So they normally start their negotiations with the hospital groups at September. And keep in mind that this is different to your price increase negotiations with the funders or with the hospital groups, because as you know, they've got different risk sharing agreements with them. Once they agreed on a percentage, your tariff codes or the recommended NHRPL or the reference price list, that percentage will then get applied as well. So it will only be revised once a year, and then it will be published in the next year. But if it's a brand new code, like I've explained now, the cardiolithotripsy, they can do a brand new code at any given time. Yes, Mark.
Perfect. Thank you.
Hi, Linda. Good morning. Just firstly a question and then maybe a comment. The NHRPL, my understanding is that that was basically discontinued through the actions of the Competitions Commission in 2006. And I think what most providers are using are their own coding systems. This would be the hospitals as well as the medical practitioners. Medical practitioners, for example, would have the doctor's billing manual, etc., that is controlled through SAMA. And then just a comment, I think what this entails is the supplier and the specific provider who's going to invest and become the owner of the equipment, collaborating as far as HTA is concerned, where while there's no mechanism for a specific supplier, and I really speak from my own experience, there's no mechanism for a supplier to request an equipment code and tariff. However, having said that, this would come from the specific provider in this case, i.e., again, the hospital or the doctor. And as you said, as Linda has said, that provider, that service provider is going to be asked, well, listen, prove to us that it is cost beneficial, etc. Please submit an HTA. So your role as a supplier is going to be one of providing as much information into that process as possible. I hope that makes sense. Happy to discuss it further.
Thanks, Mark. You're quite right on the NHRPL, but just a comment on that. Your NHRPL, although it does not exist, they still use that as baseline. So what the funders do, and you can go, and I've got actually different websites. You can use the Health Tariff Man, you can go on to MedScheme, and you can see per fund and although the codes will be exactly the same, the rand value from fund to fund will be different, but the baseline was still exactly. So the code is still exactly as it was in 2006, but the rand value per fund has changed.
Correct.
And maybe what we can do, guys, to assist you, Tim, is I can send you all these different links that will help you to get an understanding or a full comprehensive list. To say if it's a GP specialist, what is the current tariff code? What is the rand value of the specific scheme? And I think that will just make it so much easier for you. All that information is available in the public domain, and everybody can search for the different tariff codes.
Highly appreciated. If that could be shared with, I think everybody on the call would appreciate utilizing that. Or if you can send it to me, I'd highly appreciate it. There's you very much for that.
All right, that would be great. Tim, I'll ask Caroline to send that through to all of you. MedScheme's one is very nice. You can go to, there's a link. If it's a GP, you will click on the GP and it will actually bring up the tariff codes you can charge, also with the different rand values. And also a very nice one that can assist you is the Healthman tariff card.
Thanks.
Any more questions on tariff codes or how to obtain or how to prove or get approval? Okay. I don't see any hands. So guys, from our side, in closing.
I see Tanya's hand is up.
Sorry, Tanya, yes.
Hi, Linda. Thanks so much for covering this. The SAMET office has frequently been asked these kinds of questions by members. So this has been extremely valuable. So thank you. Just if I can mention to the members that are on board or present, please, if you are struggling or you have questions that you don't have answers to in the market access or reimbursement space, to forward them to the Market Access Committee. There is a dedicated email address in this regard. You can find it on the SAMET website. Maybe Caroline, if you could just pop it up in the chat. box, that would be helpful. And then, this helps us to identify where there are gaps or challenges, and also helps to inform the market access member forums going forward and what topics and speakers we should have at these forums. So if you have some ideas of what you want to learn more about, or if you have any ideas of good speakers that you've heard in this space at other events, please do let us know.
Thanks, Tanya. All right,
Hi,
guys.
Linda. Hi, sorry, Stanat. Just one last question. The presentation from Discovery will be shared as well?
Yes, I can share the process with you guys.
Linda, just so that I can clarify for that. So Discovery's presentation will not be shared. Dr. Whelan has opted not to share it with members.
Oh, all right. Thank you.
Okay. All right. Cool. Thanks.
Okay, guys, if there's no more further comments, in closing, I would like to thank our speakers for taking the time to address our members. I would also like to thank each and everyone who participated in this forum, and we hope to see you all at the next future market access forums. And like Tanya said, guys, if there's a need or a specific area you would like us to address or get relevant speakers in, please send your comments through to us and we will look at that. Thank you so much for your time, guys. Enjoy the rest of the day.
Thanks, everyone. Bye-bye.